We have two final presenters on incidental findings, both of whom have contributed greatly to this subject. We'll hear first from Dr. Eric Parens, who's a senior research scholar at the Hastings Center. In this capacity, he investigates how we use new technologies to shape ourselves and how emerging science shapes our self-understanding. He's directed a wide range of research projects, including ones on the disability community critique of prenatal genetic testing, the technological enhancement of human capacities, and on the meaning of results from neuroimaging technologies such as fMRI. He currently serves as an adjunct professor in the program in Science, Technology, and Society at Vassar College, a visiting fellow at the Bioethics Center at Yale, and a fellow of the Center for Neuroscience and Society at the University of Pennsylvania. Previously, Dr. Parens served as a consultant to several government and non-governmental bodies, including National Bioethics Advisory Commission and the American Association for the Advancement of Science. Welcome, Dr. Parens.
Thank you very much, Dr. Gutman. I'm grateful to the Commission for the chance to participate in your conversation about incidental findings. For the extent to which I have a worked out view on this matter, I'm grateful to Paul Applebaum and Wendy Chung, who have generously shared with me their insights and their time. I'm also grateful to the ELSI program, whose support makes possible the sorts of collaboration that I've had the privilege of sharing with Drs. Applebaum and Chung, as well as with many others at Columbia and at my home institution, the Hastings Center. So the Commission has asked me to kick off this conversation about the question, how can the term incidental findings facilitate or impede consideration of the underlying ethical issue? So it seems reasonable to begin with the question, what is the underlying ethical issue? As I understand it, it's an incredibly broad issue. It goes something like this on my understanding. When research subjects or patients or consumers submit all or some part of their bodies for analysis, of all of the information that in principle could be sought and returned, which information should be sought and returned? That underlying ethical issue regarding what information could and should be sought is old and is complicated, and it's made still more complicated by new technologies, as all of you well know. And nowhere are those new complications more obvious than in the context of the genome sequencing technologies that I'm going to focus on today. Alas, before I can speak directly to the Commission's question concerning how the term incidental can facilitate or impede discussion of the underlying issue, I need you to bear with me as I rehearse some basic facts regarding the process of creating useful genomic information. So speaking very schematically, creating useful genomic information entails at least 3 steps. The first is to gather data, a 3 billion base pair sequence. That raw data by itself is not meaningful to anybody. The second step is to apply a filter to look for a gene sequence or sequences that are of interest. The investigator can create a filter to pick out as few or as many sequences, as much information, that is, as she wishes. She can filter for 57 genes or for 1. The difference in human effort between filtering for 57 and filtering for 1 is a matter of a few keystrokes. Now, the third step is to validate and interpret that information, where that is, the third step is to confirm that the finding is what one initially thought it was, and often then to determine whether the finding means what one initially thought it meant. Please notice today, in practice, it still does take more effort to validate and then interpret 57 findings than it takes to validate one. But as the filters and reference databases improve, and they are incredibly rapidly, and as the amount of effort entailed by validation and interpretation thereby diminish, it really will require as little human effort to test for 57 genes as to test for one. So the burgeoning technological capacity highlights some relatively specific ethical questions that increasingly press upon us and that we need to face squarely. Among them, I knew this was going to happen, is some information potentially so beneficial that looking for it and returning it should be mandatory? This is a question that's familiar to all of you from the recent ACMG recommendations. When clinicians are looking for one clinically actionable finding, should they, while they're at it, look for 56 others? And of course, the ACMG recommendations was, yes, they ought to look for the 56 additional ones while they're at it. A second question, is some information too expensive to look for and or return? A question that you've heard over and over in the context of research. Would the time entailed by having to return results of genetics research essentially bring the research enterprise to its knees? Is some information potentially so harmful that looking for it should be prohibited? A question that will arise in the prenatal context and will be attended by very familiar concerns about eugenics, which I'm going to say a bit more about in a moment. Answers to those questions are going to entail considering many variables. I mentioned three only here. The first one, about which Professor Richardson will speak, I'm sure. What is the professional role of the person engaged in the activity? What is the context in which she's engaged? Are we talking about research, clinical care, prenatal care, or direct-to-consumer scanning, which I'm going to take to include kind of recreational scanning of companies like 23andMe? What is the nature of the trait? Is it, are we looking for a disease that can be treated, one that can't be? Are we looking for a trait that isn't related to a disease at all, et cetera? What's the strength of the result? How analytically valid is it? How much phenotypic variance does the sequence actually account for? Is this a really meaningful or not terribly meaningful result? Okay, so finally, I can begin to identify a couple of ways in which the term incidental can facilitate consideration of the underlying ethical question that we started with, and that, as we've just seen, entails so many variables and so many relatively specific ethical questions. So in medicine, the term incidental has of course traditionally referred to a finding that was not sought but was stumbled upon. Insofar as the notion of incidental findings has a long history in familiar medical contexts, when we use the term incidental in the context of genetics, it may indeed help us to resist genetic exceptionalism. It may help us to resist the notion that there's something ethically special about these findings because they're genetic. And as you're all well aware, the term incidental is, in at least some parts of the so-called incidental findings literature, already being used in a sense that's much more expansive than that traditional sense. I already mentioned the ACMG recommendations, which refer to those additional 56 sought out, filtered for findings as incidental. Elsewhere, too, incidental is already being used in a more expansive sense. For example, it's my impression that increasingly when we, and by we I include myself and my colleagues, when we talk about the return of research results, we have a tendency to use the term research results and incidental results interchangeably. So insofar as a more expansive sense of incidental is ever more commonly deployed in the literature, we could think of incidental as a term of art. We could just accept that it's not possible or that it's too costly in terms of academic energy to try to retain the more familiar or traditional sense. So now, moving from a couple of ways in which the term incidental can facilitate consideration of the underlying issue that we began with, I want to identify a couple of ways in which the term incidental can impede consideration of that issue. Given that in colloquial English an incidental finding is one that's stumbled upon or is unintentionally discovered, we might say that it is terminologically sloppy to use incidental to refer to findings that are intentionally discovered. As a general matter, technological sloppiness doesn't conduce to productive conversation. Referring to findings that are not incidental in the traditional sense as incidental is not only terminologically sloppy, but I fear invites ethical sloppiness. That is, terminological sloppiness here can, though of course does not have to, terminological sloppiness here can become complicit with our desire to turn away from the underlying ethical issue we started with. Of all the information that in principle could be sought and returned, which information should be. So imagine this. Imagine that rather than talking about the research context or the context of clinical care invoked in the recent ACMG recommendations, we're talking instead about the prenatal context. An OBGYN recommends the analysis of fetal DNA because she wants to determine whether a rare single gene disorder is present. Should the lab that returns the analysis of fetal DNA include information only about that disorder, or should it include information about additional traits as well while they're at it? If we're going to test for additional traits while we're at it, which traits should those be? Referring to those additional fetal findings as incidental risks obfuscating what's going on here. We won't have stumbled upon those additional findings. We will have filtered for them. We will have intentionally sought them out because we want to do something with them, whether that something is to treat a disorder in utero, or it is to help prospective parents prepare for the birth of a child with a disability, or because it is to help prospective parents reach a decision about selective termination. Using incidental in an overly expansive sense could obfuscate what's really going on here and could thereby undermine the sort of ethical analysis and democratic deliberation that everybody in this room is committed to. So I want to suggest that to face squarely both the underlying and the relatively specific ethical issues I've mentioned, it might be useful to continue to try to make some distinctions among types of findings. I offer here a very tentative 4-part distinction in the hope that it can prod all of you to come up with something better. A primary finding is the target of the investigation. The target of the investigation is A, and somebody finds something directly relevant to A. An incidental finding is indeed stumbled upon. The target of the investigation is A, but somebody stumbles across B. A secondary finding is sought out or is filtered for. The primary target of the investigation is A, but one intends to look for B through F too. The final type, and I don't like this label much, general findings are, in a sense, untargeted. The investigation's purpose is to look for A through Z. Think about recreational scanning, to take the easiest example. In sum, as our technological capacity increases, as the human effort required to test for 57 genes or 507 genes is no greater than the effort to test for one, so increases our responsibility to choose which keystrokes to make and which not to. The 57th gene that we find isn't incidental in any traditional sense of the term. We filtered for it, we sought it. To aid us in living up to our responsibility to choose which genetic information to look for and which not to, it may help to be terminologically tidier than we have been of late. The problem with terminological sloppiness is that it can contribute to ethical sloppiness. It can become complicit with a desire to turn away from the underlying issue that genome scanning technologies raise in an especially vivid way, of all the information that could be sought and returned, which should be. It's true that if we were to continue on our current path using incidental in an increasingly expansive sense as a term of art, we could conserve some academic energy. My concern, though, is that that energy savings might come at too great an ethical cost. It might come at the cost of open and clear deliberation about what we are and about what we should be doing. Thank you.
Thank you very much. That was really very clear and very helpful. And we're going to, rather than take questions right now, I'm going to ask our second presenter, Dr. Henry Richardson, to speak. And I'll just offer a brief introduction. Dr. Richardson is a professor and senior research scholar at the Kennedy Institute of Ethics at Georgetown University. He has worked principally on the nature of reasoning. Individual reasoning was the subject of his first book, Practical Reasoning About Final Ends, while collective reasoning was the subject of his second, Democratic Autonomy, Public Reason About the Ends of Policy. The second of those books won the Herbert A. Simon Best Book Award in Public Administration and the David Easton Award in the Foundations of Political Theory. Dr. Richardson has held many prestigious fellowships, including a fellowship in ethics and the professions, where I believe he and I first met, a fellowship from the Woodrow Wilson International Center for Scholars, a Humboldt Fellowship, 2 fellowships from the National Endowment for the Humanities, and a Lawrence S. Rockefeller Visiting Faculty Fellowship at the University Center for Human Values at Princeton University. Henry has also served as a visiting scholar at the Bioethics Department of the National Institutes of Health. It gives me great pleasure to welcome you, Henry. Thank you for being with us.
Thank you, Dr. Gutman. It's a pleasure to be here and a pleasure to be able to talk with the Commission about incidental findings in these 3 very different settings of medical research, clinical medicine, and direct-to-consumer medicine. I've been told that the Commission has been exposed to my partial entrustment model of ancillary care obligations, and what I'm going to try to do is sort of recap it in a way that directs it towards these 3 different contexts where different lessons come out than in medical research. I'll be focusing on the way in which the model zeroes in on what I call transactional duties. I'll explain what I mean by that. I'll talk about the relationship between ancillary care obligations and obligations regarding incidental findings. They're somewhat overlapping but not equivalent. And then I'll get to the three contexts. So first, a little moral philosophical terminology, just how I'm using some of these terms. I'll be distinguishing between general moral duties and special ones. General moral duties are incumbent on all persons, no matter who they are or no matter how they have transacted with other people. So obviously enough, that leaves two types of special duties. Then there are ones that are incumbent on people because of who they are. Either they're members of a certain nation or they're somebody's father or somebody's child, say. And then the ones I'm going to focus on are the transactional duties, which are duties incumbent on somebody, moral duties now, especially because of how they have transacted with somebody. Examples of the general duties, I'll be talking about general duty of beneficence. I think that a version of, or the general duty of beneficence is in need of specification and remains a duty that we can specify. Transactional duties, very important in this kind of context, are the broad category of voluntary undertakings where your pair of people voluntarily undertake that one of them will have an obligation to the other. It can be a promise, but importantly can also be entering into a fiduciary relationship. That's a transaction between people. And I'm going to be talking about what was the title of my ancillary care book, Moral Entanglements, which I think is a really interesting category and what I'm going to try to generalize to the, or take over to the direct-to-consumer context. So let me explain what I mean by moral entanglements. It's a category I think the philosophers have neglected but should pay attention to. They're moral obligations that arise independently of either party having intended it from a transaction between them that's perfectly innocent. So, neither party has done anything wrong, they interact, and without either of them having intended it, an obligation arises from one to the other. Now that sounds very strange, but I think when you think about ordinary life, it's actually quite common. And a story I like to use to remind you of the familiarity of it is my story of the old woman in the groceries. You're walking along the streets here in Philly, and you see an old woman struggling with heavy grocery bags. You say, "Can I help you?" She says, "That would be great. I don't live far from here." But it's a couple blocks, and as you're walking, you notice she's having trouble hearing you and walking and can't see very well. You get to her apartment building, and she said, "I live here just on the first floor. Would you mind putting these on the kitchen counter for me?" And you say, "Sure, I'll do that." You go in and you see the kitchen counter, and it's covered with dirty dishes with food scraps on them and blooms of black mold growing up all over the place. I don't know what exactly you should do in that situation. It's going to take some creativity and tact to act rightly, but I think you ought to do something to help with that problem. If it's just calling the social services people or whatever it is. You've helped her already. It's a perfectly innocent transaction. It's more than innocent. You helped her, but you've been entangled in her life in an unexpected way that's morally significant. Now, ancillary care. So part of what I'll be doing is I'll be dropping ancillary care at the end when I get to direct to consumer. But just to remind you of when we were dealing with this ancillary care issue in the bioethics department at NIH, the issue hadn't been touched, and we defined it negatively to begin with, and defined it for the context of medical research. So the care that subjects need that isn't covered by any of sort of standard reasons why researchers would have an obligation to provide care to their participants. So not covered by requirements of sound science, not covered by keeping the people safe, and not covered by, if you had to promise care to them to get them into the study in the first place. So the ancillary care was just the care that the subjects need, but that is left over then outside those rationales. Just this negative definition. Examples would include if malaria researchers encounter schistosomiasis, a different parasitic disease, or if somebody doing a study of a new virtual colonoscopy machine or protocol discovers pancreatic cancer, or, and this was an important historical case, a historically important case, if you're doing an HIV vaccine trial and you discover people become HIV positive, what do you owe with regard to, or they would have need for care subsequent to that for their HIV. On at least traditional readings of the term, I think the first two of these are incidental findings, incidental to the research being conducted, but the last, of course, is not, because that HIV positive status is the thing you're looking for in an HIV vaccine trial. It's the key study endpoint. But the care that comes after the trial is over is not required by science, not required by safety. It's ancillary care. I've argued that there are several kinds of grounds for ancillary care obligation. There are general grounds in the general duty of rescue being most important. So sometimes just these considerations of it being relatively easy to save someone from dire peril kick in to say you ought to provide ancillary care. And what was sort of more interesting about the partial entrustment model that we developed was that we also argued that there's a special ancillary care obligation that researchers have to their participants in particular, which is something that intuitively researchers seem to think as we went around and talked to them. And my argument has been that the special ancillary care obligation is grounded in a privacy-based moral entanglement, and it has a scope that doesn't cover everything that you might find out about a participant, but it covers what you find out by carrying out study procedures, which is the case in the three examples I've just given. So I wouldn't ordinarily jump into this, but since I've been told you were exposed to the model, I'm just going to give on this slide the moral entanglement-based argument for the special ancillary care obligation, or I'm going to give a schematic indication of my argument for the claim that there is an obligation arising from moral entanglement. It starts from these three background moral considerations. People have privacy rights that are in play. There's the general specifiable duty of beneficence, in need of specification, but also capable of specification. And then there's what might be thought of as a special case of the duty of beneficence, which is the duty to warn. Itself a special case maybe of the duty to rescue, because it's usually quite easy to warn people. So there's a crucial transaction at the beginning, which is that when participants enter a research study, they enter it by waiving privacy rights, or they enter it by giving informed consent, which crucially has the effect of waiving privacy rights in the sense that they say, yes, you can touch my body in these ways, you can take my bodily fluids, you can take my medical history. And I argue that this solicitation and acceptance of waivers of privacy rights by the researchers transfers to them a special responsibility with regard to those privacy considerations, with regard to what the privacy rights protect. A first blush response to that would be, well, okay, they better be very careful about that information and be tactfully silent about it, perhaps. But in cases where there's an important ancillary care need, the duty to warn will kick in to negate that route. So you can't be tactfully silent about it. And so your second option for fulfilling your special duty with regard to them, your special responsibility with regard to the participant, is to be tactfully engaged with them. So you're going to be positively engaged about this matter you've discovered, still, of course, being tactful, as you always would. So this is a special duty of positive engagement towards them, consequent on the transaction affected by the duty to warn, and that, I argue, provides a hook on the basis of which to specify the general duty of beneficence to generate the special ancillary duty of care. So that's moral entanglement generating the special duty of ancillary care. What I want to do in the time remaining is to broaden things out to get to your other context, the other two contexts. So you can just redefine ancillary care obligations more broadly as obligations that arise for reasons incidental or ancillary to the aim or focus of the relationship, and can define the special ancillary care obligation more broadly to mean an ancillary care obligation arising from privacy-based moral entanglement. Here's a schematic diagram of how I see the key differences among your three contexts from the perspective of my approach. Of course, famously, the context of medical research differs from traditional clinical medicine in that medical research is aimed at generating generalized knowledge. And so this affects what obligations arise in the context of medical research and how it's different from clinical medicine in a crucial way. I find the new world of direct-to-consumer medicine very hard to understand, and I'm learning by the minute more about it as I'm here, but it seems, as best I can tell, to have the same aim or focus generally, to be promoting the health of the patient. I mean, money is involved in all these contexts, so that's not a differentiating factor. The money may seem more prominent in the direct-to-consumer context, not because it isn't there in traditional medicine, but because in the direct-to-consumer context, you don't have this regulated monopoly that you have in traditional medicine, and you don't have a well-understood fiduciary duty that attaches like you do in clinical medicine. As I've argued in the context of medical research ethics, the special ancillary care obligation adds a lot. In relation to traditional clinical medicine, I don't think the special ancillary care obligation adds much. I think you could talk about it. I think there might be some boutique cases where it added something that the fiduciary obligation of a physician didn't, but it's probably not that helpful. So the interesting context is the one of direct-to-consumer medicine. And there, I mean, I guess sometimes a physician is present, sometimes a physician's fiduciary duty might be thought to kick in there, although it's not a standard context. But I guess often a physician is not present in the direct-to-consumer context, not where the physician would need to be helpful. And so let's suppose that the traditional fiduciary duty of a physician doesn't apply in the direct-to-consumer context, then what? So things would look like this. You'd have the big oval indicating what the traditional physician's fiduciary duty would cover if it were there, but it isn't. And if you just had the commercial agreement otherwise, then a special ancillary care obligation would add to that. But I'm actually, as I said, I'm going to suggest that the term ancillary be dropped out, because the really interesting question is, how could one get back something like the fiduciary obligation that's there in the traditional context of clinical medicine? And I could, here we go. So drop out the ancillary bit and just focus on the transaction. The transaction is the same in all these cases. There's a waiver of privacy rights that says, yes, you can touch my body, you can image it, you can take my gene sample, whatever it is. And so there's the same transfer of special responsibility to the professionals, whoever they are, whatever type of professional they are, which means that they have this. And then it's an entanglement if there's something unexpected, right? It may, if it's not unexpected, then it's just a straightforward fiduciary duty. It's not going to be quite as broad as the physician's traditional fiduciary duty in clinical medicine, because I think, at least if it goes by a privacy-based moral entanglement, you're not going to get a duty to hunt, whereas a traditional physician would have that. But otherwise, you get something much like the fiduciary duty. Thank you.
Thank you. Thanks very much. I mean, these are a great pair of presentations. I'll begin with a question and then open it up to other commission members. So I'm going to start with Eric, where you ended, because I think it was particularly helpful, the distinction you made between incidental and secondary findings. So just tell me if this is a friendly extension of what you're saying. Incidental findings traditionally, or the way they first came up, and they still come up often, that somebody stumbles on somebody who's looking at whether it's an X-ray done to look for one kind of malignancy, stumbles on something totally different that's troubling. And that will happen serendipitously. And that's a true incidental finding in the traditional sense. But once you take up the ethical question of what you should do with incidental findings of the traditional sort, if you're just a thinking human being and understand the practice of research or medicine or DTC, have to ask the question, what should our general rule or general practice be since there are these incidental findings, should we actually expect and ask the people who find them to look for them rather than just to stumble on them, since some of them happen maybe more often than others, and it would be really helpful to the human condition of those whose incidental findings they are if we didn't just say, ethically speaking or medically speaking, oh, if you stumble on them, this is what you should do, but you create a practice of actually looking for things that are not the primary purpose or intention of the study. Is that basically what secondary findings are, which would mean that they are intimately connected to the ethical problem of incidental findings? Because if you're an ethical observer, you'd have to talk not just about the stumbling kind, but also about what practice we should have with regard to these findings that aren't the direct purpose of the research, the clinical practice, or the DTC. What I'm suggesting is that it isn't that we have to, when we ordinarily talk about incidental findings, include the idea of secondary findings.
Yes. And
That's but I mean, I think it's important that it's intimately connected.
Indeed, intimately connected, and I think worth distinguishing in the context of a policy conversation.
But if we're going to make recommendations as a commission, I think that means in any recommendations about incidental findings have to include recommendations about secondary findings, because otherwise we wouldn't be talking about general practices. We'd just be talking about stumbling. Whereas once you know people stumble on it, you have to, ethically and practically speaking, talk about the general practice of what to do. And sometimes that general practice will be, we don't want people just stumbling on these things. We want to ask them, if you're looking for this, you should also look more broadly, and here's what you should do once you do that.
Indeed, and I think sometimes we might anyway, in principle, say, let's face the fact that there's the possibility of looking for something else, and for these reasons, we don't want to look for those. the prenatal context was.
Absolutely. I'm not saying that I'm not prejudging the answer, mind you. I'm not saying this means if there could be secondary findings, we ought to look for them. I'm saying that you have to ask, should or shouldn't people look for them? And the other thing is, if you can't help but look for them, because sometimes looking at X-ray, a trained eye can't help, should or shouldn't you report them? The only point that I'm making is it would be not only, it would be, let me put it bluntly, it would be wrong, indeed foolish, of anyone who's doing a study of incidental findings not to include the question of secondary findings.
That sounds.
Okay.
May I follow up and just, by the way, I agree with, excuse me, I agree with the two of you as well. But I have this concern about the expectation of what can come from a secondary study. In the case of genetics, or in the case of a blood study, when I say, yeah, I'm really looking for this particular factor, but let's go ahead and look for X other factors or 56 other genes in your particular case, there is every expectation that I will receive back as a physician a definitive, what I would call something with high information content result. When there is human interpretation involved, as there may be in reading an X-ray or radiographic study where it's being read by a soft tissue specialist for a specific purpose, but it turns out that there is evidences of osteoporosis or bone, bone cancer. I don't know. I'm making that up, of course, but the fact is that to say that every X-ray should be evaluated for a whole host of possible secondary issues requires a different set of expertise to evaluate each X-ray. In other words, the data coming back aren't definitive. So I wonder about setting an expectation or a requirement around secondary studies that may actually be unreasonable in some cases. Any comment on that? Do you see the point I'm trying to make? Secondary findings.
I thought maybe you would.
Do you want me to answer? I mean, I think that that's the ethical question, which is, should you expect if there is the let's take the clinical setting. You really have to use some kind of example here. So in the clinical setting, if a doctor suspects that there's some malignancy and performs an X-ray for that purpose. I mean, I'm using something very traditional just to show that this isn't something new, and finds something unexpected. That's unproblematic. I mean, everybody. Then the question that Jim is raising is, when should you have a practice that asks for looking at more general, something that you would find more, and you'd intend to find more than your primary target. And Jim, there's no general answer to that question. I mean, I think you have to look at specifically what good would come of looking for more. And of course, you also have to ask, can you, in your case, in the case you gave, you're actually looking for more. You're doing 57 rather than one.
There are many variables at play. One of the variables I didn't mention was the amount of effort that is actually entailed. The reason why I went through the genomics example is that, different from the one you're imagining, Jim, we can, with a keystroke, get as many good, that's the, yeah, and so that's an important variable that it's hard to keep an eye on. And of course, the problem with me is I'm always thinking of the genomics example and sort of forgetting the others, but the variety, the variation is really important.
And the need for interpretation is different. That's the other point I'm making, it's not necessary. There are certain kinds of tests that are so definitive, interpretation isn't required.
And you'll see that in our preliminary recommendations, we break this down into different contexts dependent on what the expertise of the person doing the testing is to interpret more than what the test was designed to do, what the benefits are in reporting them, what the, actual not only benefits but potential harms are for reporting it, and a series of factors. I have a
Christine
list.
also.
No, I have Christine, but I have Nita first, and
Dan,
then Christine. Yes.
and then Dan.
Yes.
I'd like to shift to the model, if you don't mind, to build out something that I've been grappling with, both in reading your work and in the presentation you gave, which is to focus on the issue of the duty to warn, and to understand what gives rise to the duty to warn. So you mentioned in your presentation today just that maybe it's a special duty that comes from beneficence, and that it's relatively easy to warn people, and so that's part of the rationale for the duty to warn. Although that isn't always true in every context that it's easy to do so. But I'm hoping that you could elaborate a bit more for exactly from your perspective and in the model, what gives rise to the duty to warn, and what's included within it. So what does that mean? Is it really, if we build on Eric's model and look at secondary findings, once you're aware, for example, of a regular incidence of secondary findings, you might have a duty to warn before the study begins that your privacy might be compromised in that particular way because it's something that we come upon so often. But if you could just elaborate what's included, and I'll tell you the context in which I'm thinking about this is in the legal context, you have to have a particular type of relationship between individuals that would give rise to the duty to warn. It would only extend to certain people. So if I'm a landowner, for example, and I become aware of a condition on my land, then I will have to warn known invitees to the land, but not necessarily trespassers who come upon it. So, trying to understand that would help, I think, and then understanding it in other contexts, because as you apply it to the DTC context, I'm not sure how I see the duty to warn would, if at all, arise.
Okay, good. So picking up with the last point, that's very helpful. There can be inhibitions on warning people that come from minding your own business considerations or privacy considerations. Relationship can put those out of the way, and there is a relationship that can do that in all these cases, whether it's with your physician or a researcher or a direct-to-consumer purveyor. I think, they're not precluded from warning by it not being their business. And I was thinking the source of the duty to warn as being, I didn't mean it was a special duty, but that it was a special case of the general duty of beneficence, or even a special case of it via it being a special case of the duty to rescue. So duty to rescue is a duty to save people from dire peril, but when you can do so easily. And so I was thinking of the duty to warn as I was using it as saving people from dire peril by giving them a warning. Look, you got a problem here, which is usually very easy. Although one of the interesting things about, say, research with banked samples is, you can lose track of the proband, the donor, and then it can be a little bit of a problem logistically to warn them. But it's.
But I'm sorry. So it is on the duty to rescue, because I thought that might be part of. You've mentioned that a few times. But your duty to rescue, generally given respect for autonomy, we don't impose a duty to rescue upon individuals, and we might favor, particularly when you've created the condition of danger for another person, or created a condition whereby the person needs to be rescued, a particular duty. And there are certain relationships and special relationships, parent-child, other types of relationships that create the duty to rescue. But I take your duty to warn to be a lot broader than that, on the idea that if it is easy to do so, you should step in. And if you could just explain how you would balance that with the autonomy and respect for the individual in imposing an additional duty.
Well, on my understanding, the respect for autonomy would limit the scope of a legal duty to rescue, but that there's a moral duty to rescue that's much broader. You pass the child in the drowning pond is the the stock example. Where there's no relationship, you can get the child out of the pond. You ought to do so. Especially in this country, the law is chary of doing that, and for good autonomy-based reasons. But I wasn't speaking of the law.
So what Henry is speaking of is, if you thought of it as a Venn diagram, which would be the circles of legal duties and moral duties intersect, but they don't completely overlap. So moral duties are broader than legal duties, and some legal duties aren't moral duties, they're just legal duties. And I think almost every moral and legal theory has that. While they may have different content, they all agree that they don't complete. So when you speak of duties, you're speaking of moral duties, and it leaves open the question of whether there should be a legal duty.
So I completely agree. These are not perfectly overlapping concepts. So I wanted to understand where for you the duty to warn begins and understand the basis for that duty, because it seems like a lot of the later action in your model comes from the duty to warn. And so giving kind of depth to what the scope of that duty is, I think would be helpful in applying it to these different contexts.
Yeah, so I can't really do more than say that I see it as a special case of the duty of rescue. So and that would qualify the understanding of the duty to warn. So it means it bears on cases where dire peril of some kind is in play, and it suggests that there's some limit to it, depending on how costly, again, or difficult it is to provide the warning.
You're very, I mean, the way you say it sounds, you can't say more than that, but it's actually just logically inseparable to I mean, if you have a duty to if it's easy for you to catch somebody who's falling, and so you have a moral duty to catch them if you can and easily, surely you should also have a moral duty to warn them if you see that they're about to fall. So I think those two moral duties are just one and the same. I mean, it just happens that sometimes you see people who are falling, and other times you see them about to fall. And in each case, if you have a moral duty to one, you certainly have a moral duty, if they're equally easy to do and the peril is equally great. Seems to me it's just logically inseparable.
Yeah, again.
And I think it seems to you. I think I'm just trying to I don't think, and
I mean, where it's warning, the butting in considerations might come up intuitively more prominently in the verbal warning, or in the warning than in the just catching somebody.
well, it depends on what you have to do both of those. I mean, if you have to push other people aside to catch somebody, that's more complicated than you can just
Right.
move over. If you have to interrupt somebody who might be doing something, autonomy-based, like committing suicide, where there'd be a real, argument about what, but if it's clear that all you have to do is say, you're about, stop, because they're clearly not intending to fall. All I'm saying is, I think you have a very strong moral basis for your general case. How it applies in particular cases will depend on the details of the case.
I think it's bedrock, and I just wanted to be
Yeah.
sensitive to the autonomy-related concern about butting into somebody else's affairs. But in these cases, you've got a privacy waiver that got the relationship going to begin with, so you're already in a relationship of relevant kind, I think.
Christine. And then I have Dan, and then I'm going to ask John, who might have a question. Okay.
Thank you both for today and for the work you've done before. My question is about filtering. Eric, you mentioned it specifically with respect to genetic sequencing, but in the literature, there are references to, if we have to return incidental findings, we'll filter by anonymizing, or in other words, pull further away from our entanglement. So I wanted to ask, whether or not, see, moral entanglement seems to be a little bit discretionary. You know, you can decide to walk the woman to her house or not. Once you do, you take on certain obligations that you wouldn't have if you decided not to. But there's nothing that says you have to, right? So in the front end, could you filter? Could you say, I'm the researcher, therefore the extent of my moral entanglement is going to be circumscribed by how I filter the data that I'm collecting. And is that okay in the context that, and I'd love to hear from both of you about that.
So in these cases, everybody's walking the woman to the house in the sense that there is this, they are engaged in this relationship where this private information is being collected, and so they've even gotten to the point of getting in the house. And so the analogy would be more, what if they make a practice of whenever they help somebody in with the groceries, they make a practice of putting on a blindfold and say, just tell me where to put them. That would be, and what I argue about that is that if you're filtering just in order to evade moral responsibility to help these people out, I can't say that's wrong, but it seems morally criticizable. It seems to me like going to the beach and you're a great swimmer and you just know there's this likelihood you're going to be interrupted by some kid out there who thinks he needs to be rescued, and so you're going to avoid that bothersome necessity of having to jump up to rescue kids out in the water by getting yourself blotto drunk, and so nobody would think of calling on you. I just think it's criticizable to blindfold or limit yourself, or just to not do the keystrokes or do the keystrokes to filter things out, just to avoid that. If you've got other reasons because it's costly, or if it's a matter of human interpretation of x-rays, that's a totally different matter.
Eric, do you want to say anything about filtering? Because you described the sequence of steps in genetic sequencing and as involving filtering. I mean, you make a decision up front what to filter for, right?
Indeed, and I'm prepared to believe that in different contexts, different people with different roles will have different obligations regarding filters. Though, as we all know, those boundaries between those roles and contexts is ever blurrier. But in principle, I'm prepared to say, yes, I can imagine that in one context, one would use one filter, and in a different context, another filter. We are using filters in slightly different ways, but your point is a helpful one.
Dan?
Henry, I very much appreciated your focusing on direct-to-consumer and the role potentially of your model in that area. And I was wondering if I could get you to say a little bit more about it, particularly because I think lots of folks might begin by saying, well, it's just a contract, right? I ask people to look for my calcium score in my coronary arteries, and that's what they tell me back. Or, I ask them to find whether I have X gene, and that's what I paid them for, and they tell me back. But I'm very sympathetic to your view, and some hints might be, first, you quickly threw up a slide that said what's the purpose of direct-to-consumer marketing of these sorts of tests, and you analogized it or put it exactly the same as that of a clinician, and you might get some pushback from the people who are doing the marketing of these tests that their purpose is to promote health, but in some ways I think perhaps you're right, so I'd ask a little bit more explanation about that. And then the other hint for me, going back to your little old lady with the groceries analogy, would be even if she paid you to do it, and you came into the house and found it in the disarray that you described, do you still think, because it seems to me intuitively plausible, there would be a duty from the moral entanglement even under a contract situation? So maybe say a little more for us.
Okay, that's great. I mean, it is a very intriguing context, this direct-to-consumer, and as I tried to indicate, I know very little about it. The reason I had on my diagram the purpose being the same as traditional clinical medicine is I was focused on cases which may not be fully representative of full body scans or people having their genomes decoded, not purely recreationally, but tell me what you find sort of spirit, so that so then that may not cover all the cases of direct-to-consumer body decoding, but it might. But I was focusing on the direct-to-consumer medicine side of things, which promoting health, and I understand why you would say that, but maybe the reason that you want to think of it that way is because there isn't this fiduciary obligation present, as I understand it, in that case, in which case that's what's affecting how you think of the purpose. It's just promoting health in this general way. And so what I was sketching very briefly at the end was a way of recovering something like that fiduciary duty on the moral entanglement basis. The moral entanglement, I mean, so there are contracts, and the interesting contracts that I'm focusing in on here are ones in which a privacy waiver is involved. That's an unusual. You could analogize it to borrowing somebody's car, where they've got an exclusive right to control their car. They waive that right and say, okay, yeah, you can use it. And then, but when you borrowed somebody's car, you've got some special responsibilities. If it gets dinged while you've got it out there, you've got to deal with the hassle, at least, or something. It seems a Wild West context out of there, and it seems like one where the difficult issue is, what if people are asked to waive any ancillary care obligation or any care obligation that might arise when they sign the contract? I mean, that would take a policy intervention to prevent that from happening, I think.
I realize we should just say, because this is not a household term, that DTC is direct to consumer, just for everybody to know that. John, did you have a question?
I do, Amy. Can everyone?
Yes,
can
we can.
everyone hear me?
Loud and clear.
Great. Okay. Well, I want to start out by saying how sorry I am that I can't be there in person to thank Eric and Henry for such really terrific presentations, but also for the background work of theirs on which we relied, which I find really elegant and deep. So thank you. There are two questions in this area. First of all, there's the question of who has a duty to warn or to intervene, and why. And secondly, there's the question of the strength of that duty. Does it have to be a life or death issue, or to what extent can cost figure into the equation? I want to ask you both to reflect on the relationship between these two questions, namely between the issue of whether there's a duty and who has it, and the question of the strength of the duty or the requirements in a particular circumstance for that duty to be triggered. So we're dealing here with three contexts: clinical, research, and DTC. And I've got to say, at the beginning of our reflections on this, I was hankering for some kind of unified field theory of obligation that would unify these three different areas, the clinical, the research, and DTC, rather than basing our moral analysis on ad hoc categories. I was, searching for some sort of unifying approach. And as a result, I've come to feel like Wittgenstein's fly floating around in that bottle. So there might possibly be a ground for a unified field theory through something like Henry's partial entrustment model. But as we've seen, both in the literature and in your presentations today, that there are a lot of differences between these contexts. In the clinical sphere, you might say that the duty is super justified or over determined. You not only have a a moral entanglement of the sort that Henry's talking about, but you've got very clearly articulated traditional physician fiduciary duties. In the research context, you've got some fiduciary duty, and you have something like Henry's partial entrustment model at work. And then finally, in the DTC area, we seem to be simply left with something like the partial entrustment model. So as we go from clinical through research to DTC, we find a kind of thinning out of the obligation. So I'm wondering what the relevance of this thinning out is for policy determinations with regard to incidental findings. So in other words, if the duty to assist or to warn is, say, weaker in the DTC context than in the clinical, does that weakness have a corresponding effect in the area of policy regarding how urgent the case seems to be for intervention, right? So, in other words, in the case where the duty is strongest, like the clinical sphere, you might say that that even relatively insignificant harms might come to the fore, might be something to worry about. Whereas in the DTC context, you need the level of stringency to be up there pretty high. I mean, does that sound like an accurate assessment of this moral situation? And if so, what are the consequences for policy?
I'm going to ask one of you to take a swag at that, just because we have a number of other questions. We can come back to it, but it's a really good question.
It's very good, and that's a very nice way of summarizing the relationships and differences among the three contexts, Dr. Harris. But I'm not sure I would order them the same way, because one of the key differences between research and the other two, as represented by the differences, however exactly we parse them as between the purposes of the interaction, is research is aiming at generating generalized knowledge, and that's a socially very important task and a morally important task it's engaged in. And so that provides a reason that's peculiar to research for taking especially seriously the costs and the burdens on the enterprise if you do a lot of this stuff, whereas in the other context, it's more the individual and the professionals and the individual's need, I think, becomes more central, and the question just becomes, can one reconstruct something like the fiduciary obligation in the traditional context and carry it over to the direct-to-consumer?
Thanks. Anita?
Most of my questions have been asked by Dan and John and Nita, but I have one remaining question for you guys, which is about this. So we've been told that for some people, direct-to-consumer testing is being done as an alternative to traditional healthcare, distinctly not purely recreational, and motivated by desire to save money, because traditional healthcare may be more expensive, desire to have greater confidentiality, because they don't want certain information to appear in their quote-unquote official electronic health records. So if direct-to-consumer is becoming, or to the extent that it's becoming, an alternative to traditional healthcare, does that in your mind think that we should think about obligations to return information more like the clinical setting, where the obligation is very strong, presumably? Or do we allow the idea of business and contract and caveat emptor, et cetera, to cause us to think that, well, the obligation here is maybe only to return information that involves dire peril, but not the same level of obligation we'd have in the context of, again, clinical care?
I mean, I'll take a first crack at that. I mean, I actually think the ground for the physician's fiduciary duty is the one that I've indicated, having to do with accepting the waiver of privacy and dealing with this person's private information, say, okay, I'm going to deal with it. Of course, it's just so well understood that it's taken on a kind of intellectual autonomy on its own, as we just think that's the physician's obligation. I was casting my remarks on the supposition that the traditional fiduciary duty of a physician wasn't understood as covering this direct-to-consumer context. And so suggesting an argument for something like that fiduciary obligation in that context. But an alternative path that the commission could take would be to say, at least for these cases where it's people's shot at a cheap entree into medicine, to say it should be incorporated into this regulated monopoly of medicine, and we need to extend our conception of physicians' duties somehow to cover this new context.
Eric, did you want to say something? Yes.
Just a general observation. I'm struck by the extent to which the conversation has recently been about the duty to warn regarding something unexpected, and that's enormously important for obvious reasons. As I was suggesting, increasingly we can expect and should expect findings. I'm wondering to what extent this language of duty and autonomy can be complemented by the kind of language of learning health systems, collaboration that has begun to be articulated by people like Ruth Faden and colleagues. This is not much more than a free association, but I am myself a little puzzled by the extent to which we're talking about duty to warn regarding unexpected findings, when in fact the more and more the system develops, the more and more we're going to expect, and the more and more we're going to be talking about the obligations of everybody involved.
So I have a question from a member of our audience, which actually is an alternative that addresses this issue in a interesting way, and I'll ask him to raise his hand. Alex Guerra over here. University of Pennsylvania Department of Medical Ethics and Health Policy professor. And here's what it says. With respect to direct-to-consumer, is there any principle to objection for us as a democratic polity imposing a legal duty to search and warn in some direct-to-consumer context, just as a matter of good policy? As an analogy, consider the legal duty we impose on some professionals, teachers, psychiatrists, police, to report concern about child abuse or neglect just because of the good epistemic vantage point some of these individuals occupy. So to broaden this and putting my philosophical hat on, this turns in some sense philosophy on its head. Instead of looking for the moral foundations, which people often disagree on, this says, why not begin with some examples and ask of what could and couldn't be reported, and ask what would make good outcomes in these cases. And then you can ask, are you imposing too great a burden on the direct-to-consumer thing? But I take it this question is, begin with what would make, as a practice, good policy, taking into account all of the ethical and practical considerations. I see you have a furrowed brow, Dr. Parens.
I'm trying to get clear, which DTC context we're talking about. People who are really trying to supplement or using it instead of healthcare.
Right, so I mean, here's what, let me just extend this to Anita, because I think Anita, so if it's the case, let me just, because it isn't always the case, but that's why we need examples, and we will use them in our reports, we must, because otherwise I think it's very hard to know what's at stake. But if it's the case that there's some direct-to-consumer testing that people use who can't afford other ways of testing, and this would be a good thing for them to find out certain incidental findings, because they otherwise would go unnoted and untreated, then what this suggestion is, if I understand Alec's suggestion, is couldn't a democratic polity, as a matter of good policy, say direct-to-consumer findings of this sort should be reported?
So we're going to require businesses, free enterprises, to do this additional work. I mean, now, I suppose one could imagine a world in which that would happen. I would prefer to imagine a world in which actually people don't have to go to businesses to get their genetic information.
You would prefer that world,
Well-
but if we don't have it, you still have to ask the question, what businesses, I'm not trying to prejudge this as to that's what we should require, but I don't see why that's a bad question to ask. We ask the question of corporations, do they have a legal or moral duty? Let's begin with the moral or legal duty to report when they find adulterated items in their stock. That's a matter of policy. We don't have to require them to do it, but we do require them to do it because we think it's good policy. They could have, in the larger fine print, we have no responsibility, it's caveat emptor, but in fact, as a democratic polity, we generally impose obligations on corporations, moral if not legal, and in this case legal as well as moral, to report some things that they find, and that we don't live in a pure caveat emptor society.
That's a great question, Dr. Guerrero's, and I just would counsel thinking in terms of lots of different analogies, which is something that Alan Wertheimer does in his wonderful recent book on research ethics. So there are also the accountants who are looking at your financial information. Maybe they'll see some sign of a gambling problem. Do we want to require them? I mean, there are all sorts of, if you're going to redesign practices, you could ask the plumbers when they're checking out your house, to report other things they find. And so it's just, I think, a useful heuristic. In terms of business, I mean, we're sitting in a wonderful academic hospital, in a university hospital setting, but a lot of hospitals are businesses, as I would understand that term. So I wouldn't draw too sharp a distinction myself between business and medicine.
I have two other questions, and then we'll take a short break. We have a member discussion, so I feel we can cut into that a little bit because they're really good audience comments and questions. Is it Beto Ortiz? Right there. From the NIH. In the case of, I'm not sure we're going to have time for all of these. In the case of, what is it, incidental findings, even of the secondary kind, is the duty to warn without the responsibility of rescuing once information is given a little bit morally inappropriate, in quotes. The duty to warn should exist if rescue would follow. And that is another good question because it suggests, shouldn't we take into account what will happen most likely if an incidental finding is reported to someone, whether they will be in some sense, have some opportunity to be rescued. Am I understanding that correctly? Eric or Henry? Henry?
I mean, I brought up the duty to warn, and the only reason I brought up the duty to warn is that the key crux in my argument had to do with if people have a special responsibility regarding the concerns underlying privacy rights, wouldn't you think they had a duty to be quiet about things? And so it was to overcome the duty to be quiet about things that I reminded people of the duty to warn that says in this kind of case, they mustn't. But the duty to warn, I mean, as I've been saying, I'm thinking of it as a special case of the duty to rescue. The duty to rescue is there. For a lot of ancillary care stuff in this country, the duty to warn can do a lot of the work because you'll discharge your ancillary care obligation by saying, you've got this problem I didn't expect to find with your pancreas, you should talk to the pancreatic specialist down the hall. But of course, in developing countries, things are totally different. If you just warn somebody they have a problem, that's making their life worse, and you need to follow up with help.
But this is another case, I agree with what you've said, but it's another case where examples matter because an example of where this kicks in is there is the possibility with very little extra cost of finding out, for example, whether somebody is genetically disposed to early onset Alzheimer's, to which nothing can be done medically speaking at this point. Now, things can be done in your life, and people vary. I mean, if we took a poll, I think we'd find that there is certainly division as to whether we in this room individually would want to know or not want to know under the current circumstances, which you can't do anything medically about it. So that's where this kicks in, where is there a duty to warn about something which is truly a life-limiting medical condition for which there's no treatment?
Well, again, so it may be too limiting to view the duty to warn as a special case of the duty to rescue, but viewing it that way, then you're seeing it as a way of averting dire peril to someone. And if nothing can be done to avert the peril, then
there's
it
not.
doesn't kick in.
Right. Then on that it doesn't kick in. There's still the question about whether there's some other reason or not, but that's very good clarifying. I have one final one.
This is corollary to that.
And can you,
Yeah.
Okay, and Jim's going to read it because I'm afraid my eyesight of small print is not as good as it was 10 years ago.
You're obviously pushing the information density requirement for your students because this happens to be a student, Sudeep Rangi, bioethics. And Sudeep actually has a corollary to this question. We've been talking about the right to warn, always about concern for a detrimental finding. He writes, what if the incidental finding were findings of purely positive theoretical interest and with little burden to the subject of the consumer? Is there a moral or ethical uncertainty? I think it also raises the question about who should make the decision about what's detrimental.
Yeah.
Is it the patient or is it the physician?
Can we just ask, do you have an example, any example in mind? That you have the gene for living particularly long life, which right?
Sure, it could be that you have found that, a mother has entered into a research study because she has a child who has a genetic disorder, and so they want to do her blood sequencing. And up until that point, she believed that she was going to be infertile. She found out information that she now actually has the capability to still procreate. She did not enter into the contract.
Good.
Clinicians they're already bound by legal duties if there's a harm, if there's something they have recourse to that. But
Terrific. Thank you. By the way, this has been a terrific series of questions from the audience, so keep it up. And this is the final question before we take a break. Who would like to answer that? The furrowed brow of Dr. Parris has my attention.
It's difficult to imagine a duty to warn regarding information that is not life savings. I mean, I think
No, I don't
informed
think it's
consent.
asking a duty to warn. It's a duty to report, just
Well,
to inform.
Well, again, I mean, the process of informed
Or
consent
take
is to
duty-
make the offer to someone. And presumably, I mean, it's very difficult to work the details out, but presumably, we offer the opportunity
So-
to get access to this information. We don't just foist it on somebody.
Yeah, so that's a great way to conclude, because we've been focusing on the duty to warn or inform, but there's also the question of, in the practice, right, not the one-off incident, the practice, what you, going into the practice, what the understanding is, you know, the professional contract, if you will, the moral contract, but the real understanding is of what will and will not be reported.
And by
And
the
to
way,
the extent that we can have practices and recommend practices that are good public policy, that makes it, it reduces the traditional realm of incidental findings, and I think does what you are overall recommending to do, which is not to inflate incidental findings more than one has to. Thank you. Let's give a round of applause to Dr. Richardson and Dr. Parents. Very terrific.